My dear students, in this video, I am going to discuss about Pott spine with neurological involvement and its implication to the intensivist. This is not an uncommon presentation in many of the ICU patients, as we find that this is a case where a 50-year-old male is admitted with altered mentation for 2 days with history of 3 months of backache, low-grade fever, weight loss, and progressive weakness of both lower limbs for a duration of 2 weeks. On examination, blood pressure is 100/70, heart rate is 104, respiratory rate is 24, saturation is 94% on room air. There is localized thoracic spine tenderness along with mild gibbus, which is the deformity. The upper motor neuron signs are present in the lower limbs, that is increased tone, brisk reflexes, and extensor plantar. The power is 3/5 bilaterally, and sensory level is at T8. Now, in this patient, what are the differentials and what should be our provisional diagnosis? Now, this should stem from the clinical clues that are present in this patient. If this patient is a Pott spine, then there will be a chronic course, which is in this patient, constitutional symptoms, gibbus, cold abscess, which of course is not there in this patient, but it may be there with gradual neurological deficit. If it is a case of pyogenic spondylitis, then there will be acute onset instead of chronic. There will be high fever, there will be severe pain, and also the patient will be very toxic. In spinal mets, there can be similar presentation, but the one differentiating feature is severe nocturnal pain. Nocturnal pain is there even in Pott spine, but the spinal metastasis nocturnal pain is very severe. There will be preserved disc space early, and some known primary cancer can be elicited during history or during diagnosis. Multiple myeloma also causes severe bone pain, but there is also associated anemia and in advanced cases, renal involvement leading to dysfunction. Epidural abscess can cause, but there will be acute neurological deterioration with high fever and severe back pain. Brucellar spondylitis can also, but there will be cause similar presentation, but there will be an occupational exposure from the history, and there will be mild vertebral destruction with less deformities. Degenerative disc disease can have some of these presentations, but without fever and constitutional symptoms with normal neurology. And in lymphoma, the B symptoms will be there, soft tissue mass, minimal bone destruction would all be indicative towards it. So if you think about spinal tuberculosis, there will be fever, which is worse in the night. There will be constitutional symptoms like malaise, night sweats, and weight loss. There will be back pain and progressive kyphosis of the lower thoracic and lumbar spine. If that is the site of affection, neurological deficits such as difficulty in walking, clumsiness, and paraplegia will be present. Cold abscesses may be there in the soft tissue mass around the site of infection, and it can be seen in children and young adults. Now, in our patient, presence of constitutional symptoms strongly supports TB over degenerative causes. The patient does not have a rapid progression of paralysis, which rules out epidural abscess. The patient does not have the severe bone pain and the severe nocturnal pain, which can rule out cancer. Patient does not have painless cold abscess, which is, of course, going against tuberculosis from that point. Sharp angular deformity of gibbus along with localized tenderness suggests tuberculous spine until proven otherwise. And upper motor neuron lesions with a sensory level strongly indicate cord compression. So in this patient, there are features of chronic infective spondylitis with upper motor neuron paraparesis, sensory level, and spinal deformity, which is most consistent with Pott spine causing spinal cord compression. So what investigations should be carried out for further workup? Now, the earliest and the simplest investigation is the plain X-ray spine epilateral, where anterior vertebral body destruction, wedging and collapse of one or more adjacent vertebrae, paradiscal involvement, that is two adjacent vertebrae with intervening discs, gibbus deformity, which is classically a sharp angular kyphosis, and perivertebral soft tissue, which is suggestive of cold abscess, can all be there to a variable extent. Some of these features may be present, some may be absent. So, but they will telltale the clinical signs and symptoms. In case of earlier diseases and when some subtle signs are not elicitable in the X-ray, MRI with contrast is the investigation of choice, in which there are vertebral body findings. Like in T1, there is hypointense vertebral marrow. In T2 star, there will be hyperintense marrow edema. Post contrast, there will be heterogeneous enhancement and involvement of multiple contiguous vertebrae. The spinal cord findings, which are very important, especially in patients in the ICU where spinal cord compression is usually there, in those patients, cord compression or displacement and cord edema. So T2 hyperintensity with cord is indicative of cord edema, and myelomalacia can be there, which is a late and poor prognostic sign. So if X-ray shows anterior vertebral body destruction with collapse, reduced disc space, and paravertebral shadow causing gibbous deformity, while MRI demonstrates marrow edema, paravertebral and epidural abscess with spinal cord compression and cord edema, then it is a diagnostic. The question is, how can you differentiate pyogenic from tubercular spine on the basis of MRI? Now, as you see here, the upper portion is the A, B, C, and D. This is the pyogenic, and EFGH is the tubercular. And this is very clearly seen that vertebral involvement in TB is multiple contiguous. In pyogenic, it is usually at one level. Disc involvement is late in TB, early in pyogenic. Abscess wall is thin and smooth in TB, thick and irregular in pyogenic. Paravertebral abscess are large and cold in TB, small in pyogenic if they are present, and subligamentous spread is common in TB, but it is rare in pyogenic. So the next question would be that what are the causes of neurological deficit in Pott spine? So if it is asked in the question, then the candidates to explain each of those factors, like mechanical compression, which cause due to epidural granulation tissue, cold abscess, or sequestrated bone disc. It can be because of spinal instability and kyphosis. It can be because of vascular compromise leading to end arteritis, which causes cord ischemia. And of course, in the late sequelae, severe kyphotic deformity, gibbous, can cause late onset paraplegia. So depending on the stage of involvement of the spinal cord, beginning from radiculomyelitis to syringomyelia and progressing to spinal abscess to myelitis and spinal cord infarction, at different stages, different level of involvement of the spinal cord would be responsible for cord compression to the various extent. So how do we differentiate early onset from late onset paraplegia in Pott spine? In early onset deficit, the mechanical pressure of the spinal cord by an abscess, granulation tissue, tubercular debris, caseous tissue, or mechanical instability is the cause. In late onset, it is usually due to stretching of the cord because of severe kyphosis. In early onset sepsis, the infective thrombosis or endarteritis of the spinal vessels can cause, because that is infarction, and tuberculous myelitis and tuberculous arachnoiditis by direct involvement of the cord and meninges by tubercular infection can also happen. In late onset deficit, it is usually due to fibrotic tissue involving the dura. So early onset paraplegia is potentially reversible. Late onset paraplegia is largely irreversible and it requires surgical correction or intervention. What tests are required for microbiological confirmation of Pott spine? Now, this confirmation is strongly recommended to confirm Mycobacterium tuberculosis, detect drug resistance, particularly MDR and XDR, guide appropriate ATT duration and regime. But because spinal TB is paucibacillary, the yield will depend largely on the quality of specimen. So the preferred methods include CT-guided percutaneous biopsy, which is the gold standard, and this biopsy can be from the vertebral body or from the paravertebral or psoas abscess if they are amenable or accessible. And secondly, they can be from the intraoperative samples following decompression or stabilization surgery. Which specimens can be sent? Pus or necrotic material, granulation tissue, bone fragments can all be sent. However, now mostly we in ICUs, we are dependent on other tests, the CBNAT, the gene expert. So we are more comfortable with the result. In the molecular diagnosis, CBNAT expert, they detects the MTB DNA, identifies rifampicin resistance, turnaround time is less than 2 hours, and the sensitivity is higher in abscess material than in bone material. With expert MTB or RIF ultra, the better sensitivity in possibacillary disease and should be preferred if this facility is available. The clinical relevance is that it allows early initiation of MDR-TV regime if this resistance is detected, and WHO recommend initial test for extrapulmonary tuberculosis, that is the molecular diagnostics for extrapulmonary TB. So, how do you manage a patient with Pott spine with neurological involvement? One, of course, is the medical management, which includes the ATT. The drug sensitive spinal tuberculosis is most common. The preferred regime, which is widely accepted, is the 12-month regime of intensive phase of HRZE, isoniazid, rifampicin, pyrazinamide, and ethambutol, and a continuation phase of 10 months for HNR. The dose should be weight-based for both isoniazid, rifampicin, pyrazinamide, and ethambutol. And the medical management of Pott spine consists of prolonged, as I showed, it is usually 12 months, along with short-term corticosteroids for neurological compromise, spinal immobilization, and close clinical and radiological monitoring. And only for surgery should be reserved for cases with complications and deformities. So, what are the indications of steroids? Steroids are adjunctive corticosteroids indicated in acute neurological deficit due to cord edema, in case of severe epidural inflammation, and in case of paradoxical neurological worsening after the starting of ATT. Now, this follows IRIS, so that is the immunological reconstitution of inflammatory syndrome, but this can happen following after starting of the ATT, and there also steroids are mandatory. So the common regime is dexamethasone or prednisolone. They're usually given for short course of 2 to 4 weeks with gradual taper, and always should be given along with ATT and never alone. So steroids will reduce inflammation and cord edema, but they will not replace surgery if mechanical compression persists. So the role of surgical decompression will still be there. What are the indications of surgical intervention? Absolute indications include progressive neurological deficit despite ATT, severe cord compression on MRI, spinal instability, large abscess causing compression, and in cases of diagnostic uncertainty. There are relative indications like severe kyphosis of more than 40 degrees and non-healing disease. The goals in surgery is to decompression of the neural elements, abscess drainage if there is abscess, and stabilization with deformity correction if that is possible. How would you monitor response to treatment? Clinically, the earliest sign of response is pain relief. This is followed by weight gain. Then there is third is the improvement in the neurological function. Laboratory wise, if we go, there will be ESR and CRP, there will gradually decline. Radiologically, MRI is not advised as a routine. Only MRI can be repeated if there is worsening in the neurology or in patients with suspected non-response or in case of paradoxical reaction or iris. Otherwise, MRI should not be repeated in every patient for any small reasons. Radiological worsening early in the treatment may reflect paradoxical reaction. How would you prognosticate recovery in such patients? Now, good prognosis is indicated by early diagnosis, partial deficit, minimal kyphosis, and the start of early ATT, whereas poor prognosis occurs in patients with long-standing paraplegia or complete paraplegia, in severe kyphotic deformity, and in delayed initiation of the treatment. So if you look into this box, whenever you suspect TB spine, if the risk factors are present, the risk factors are indicated in box A, which includes immunocompromised, HIV, TB contact, or past history of tuberculosis. In all those patients, we go for spine radiograph, spine MRI, along with other investigations I indicated in the box C, like X-rays, CBC, ESR, CRP, HIV, etc., and of course, molecular diagnostics. And if we suspect spinal TB, Then we have to know whether if there is any indication for surgery. Answer is yes. Then we go for surgery, go take intraoperative biopsy and continue with multi-drug chemotherapy. If there are no indications for surgery, we go for spinal biopsy, go for medical management with multi-drug chemotherapy, and look for the presence of neurological deficit, in which case we again follow with surgery and multi-drug chemotherapy. If there is poor clinical response, we consider the possibility of MDR, TB, and also look for mechanical instability and review our diagnosis. If we don't suspect TB or if we have confusion, we go for the box D. There are the other differential diagnosis, and those can be finally the final diagnosis can be reached through spinal biopsy. So my take-home message from this case would be that whenever there is a patient with back pain along with constitutional symptoms and neurological deficit, the patient should be considered a spinal TB until proven otherwise. MRI is mandatory in suspected neurological involvement, and neurological involvement in Pott spine is often reversible if detected and treated early. ATT is essential. Surgery is adjunctive, but sometimes it is also necessary and life-saving. And always assess for late onset paraplegia in Hill tuberculosis with kyphosis, because surgical correction has a very big role in the final treatment. Thank you.